All right. So good morning, good afternoon, and good evening, everyone. Thank you so much for joining us today. I feel really honored and blessed to welcome Dr. Lim today, who will be sharing her exciting research on diabetes in Malaysia. As many of you know, Dr. Lim has been a very close friend to myself, Mo, and many other faculties from our center for many years. And it has been a true pleasure to witness her rapid growth and success in building her research portfolio in just a few short years. And Dr. Lim is currently the head of the diabetes care unit and a consultant endocrinologist from the University of Malaysia at Kuala Lumpur. She also holds an honorary position at the Baker Heart and Diabetes Institute at Melbourne, Australia. As a clinician scientist, Dr. Lim's major area of interest are cardio-renal-metabolic medicine with translational and implementation science components. She sits on the scientific work group of the ADA-ESAD Precision Medicine in Diabetes Initiative, the Lancet Commission on Diabetes, and the WHO Global Diabetes Compact. She has published more than 100 peer-reviewed articles, including the Lancet, Nature, Diabetes Care, and the Science Bulletin. Dr. Lim has received several major awards, including the world's top 2% scientist by Stanford, and the EFSD Albert Reynolds Fellowship, tenable at the University of Oxford. She's an editorial board member of several Tier 1 journals. She's also the honorary assistant secretary of the Malaysia Endocrine and Metabolic Society and the council member of Diabetes Malaysia. Now, without further ado, I am pleased to hand the microphone over to Dr. Lim. Dr. Lim.
Thank you very much, Hui. Very kind introduction. And again, thanks to Emery, Hui, Wendy, and Mo for the kind invitation to share what would be the diabetes and obesity landscape in Malaysia and perhaps within Asia, because very much dependent on the data availability in our region. Can you all see my screen?
Yes.
Okay.
Yep.
Okay, great. Thanks, Hui. So if you look at statistic, International Diabetes Federation has projected that Western Pacific region, we have the highest prevalence of diabetes. So looking at the figure in 2021, 200 million of people, projected increase by about 30% to 260 million 30 years later in 2045. And Western Pacific region, and this would have translated to about 1 in 10 adults, would have been living with diabetes by 2045. So why is it important for us to understand diabetes and perhaps obesity, which I'll actually provide more details later on, is 1 in 3 people with diabetes, they have concomitant cardiovascular and kidney health conditions, and they actually have shared mechanistic pathways. Looking at the pink box, what would be the actual mechanisms leading to the development of diabetes? Is because of insulin resistance as well as insufficient insulin secretion. And you have genetic predisposition, whether to the pancreatic beta cell dysfunction. You also have genetic predisposition for obesity, and even some are actually looking into the insulin resistance. You have interactions with multiple risk factors that have given rise to hyperglycemia. You have worsening of inflammation, oxidative stresses, endothelial dysfunction, promotion of arterial thrombosis, and hence, these people would be at risk of atherosclerotic cardiovascular disease. Then, on the other hand, on your left-hand panel, you may realize that these mechanisms can also lead to abnormal energy metabolism. It can be in terms of glycemic glucose utilization, protein, cholesterol, and all this again would have led to cardiovascular and kidney dysfunction. But besides arterial thrombosis, all these mechanisms could actually contribute to hemodynamic disturbances, RAS activation, higher demand on the renal tubular pump activity, and therefore causing heart failure and chronic kidney disease. And I'm just sharing with you what we have in Malaysia in terms of the National Diabetes Registry. So this only captures primary care diabetes population, publicly funded clinics, excluded publicly funded hospitals. When we were to look into comparison to the general population, what would be the standardized death per 10,000 population? So these results are actually stratified by cardiovascular status. Absent will be on your left-hand panel, no cardiovascular disease. On your right-hand panel will be type 2 diabetes population with cardiovascular disease. Top panel, female, and the bottom panel will be the male patients. General population, these death rates will be in pink color, while the diabetes population, their death rates are represented in green color. You just focus on your left panel will be type 2 diabetes population without prior history of cardiovascular disease. The age standardized death rates is actually about 2.5% to 4% per annum. Then what about those with type 2 diabetes with a prior history of cardiovascular disease? Of course, we expect a higher death rates is actually up to 6% per year. And in general, to my knowledge, you may know better, among the high-income countries, the age standardized death rate is just about 2% per year. So looking at that, even type 2 diabetes population without prior history of cardiovascular disease, Malaysians tend to have a higher rate of all-cause death rates. So are we just because we have not performed well enough in terms of our healthcare system, or our quality of diabetes care has not been great? By showing you here will be the global data. They're also looking into the rates of death due to any cause for diabetes and obesity population. At similar time period, 2010 until 2019, it has been unchanged. The top panel will be because of the improvement of the blood pressure treatment, because of improvement of the cholesterol management, you see a reduction of all-cause death rates for those living with hyperlipidemia or hypertension. But if you focus into those living with type 2 diabetes and obesity, globally, the all-cause death rates is actually unchanged. And therefore, showing here will be, are we really doing sufficient or enough to prevent our people with diabetes and obesity from dying? We need new strategies. And in order to understand that, we need to know, is there any gaps in the current delivery of diabetes care? So looking at the Asian data again, close to 1 million people, about 40 years of data, 1960s until early 2000. Compared to those without diabetes, people living with diabetes, they're at about 2 times increased risk of developing, or 2 times the increased risk of dying due to any cause. But we also see the similar risk if you stratify them into different causes of death. It can be due to cardiovascular disease. For cancer, even breast cancer is about 1.7, the hazard ratio. If you're looking at pancreatic cancer, okay, 1.6. If it's a kidney disease, it's higher, 3 times, with a well-known fact that Asians were actually at risk of having chronic kidney disease compared to the Western population. But is that the only thing that we can see from this big analysis? It's not. We also see gender disparity. If we were to look into coronary heart disease and ischemic stroke, the P interaction that is significant, women actually had a higher risk of developing coronary heart disease and ischemic stroke compared to men. But also observed that people who are young having diabetes, they're also at a higher risk of developing coronary heart disease and ischemic stroke, dying due to this atherosclerotic cardiovascular disease compared to those aged 50 years and above. What about kidney disease? Same trend. Compared to men, women actually have about 2.5 times higher risk versus a 2.8 for men. But do we see a younger populations actually also dying due to chronic kidney disease? Similar trend versus the atherosclerotic cardiovascular disease data, but it was not statistically significant for the P interaction. So we do see gender disparity, we do see age disparity in terms of the quality of diabetes care, in terms of the risk of death due to any cause. Would the treatment strategy also affect the quality of diabetes care that have been received by our population? There has been paradigm shift in the pathophysiology recognition, which can affect the treatment strategy while managing people living with type 2 diabetes. In the past, endocrinologists have been taught saying that you should actually balance your approach in managing insulin resistance and insufficient insulin secretion. And at the present time, we're looking into avoidance of severe hypoglycemia in terms of the beta cell dysfunction. And since 2015, we are looking into residual risk reduction for cardiovascular, kidney, and metabolic conditions, and also looking into early achievement of near normal glycemic control. If you need to be even more precise, is really trying to preserve the beta cell function. And hence, people will be saying that if we control all of the risk factors, as listed here using the Swedish populations, what will be the key risk factors in the development of cardiovascular disease? Smoking, having an A1C of more than 7%, having suboptimal controlled blood pressure represented by systolic blood pressure more than 130 millimeter mercury, or if a low risk, they actually set a higher threshold of 140. Then what about cholesterol? Total cholesterol of 4 or 155 milligram per deciliter, with a triglyceride 1.7 millimole per liter, or a corresponding of 150 milligram per deciliter. And if you get all 5 risk factors being not optimally controlled, the hazard ratio is about 2 times, similar to the Asian data which I presented to you just now. However, if you manage to get all 5 risk factors being controlled, you manage to reduce the hazard ratio from 2 to 1.2, you still have about 20% of residual risk, despite controlling all of these 5 risk factors. So is there anything else that's missing here? What would be the missing puzzles? We need to ask why. And hence, Mo is actually the key person together with Ed in the WHO Global Diabetes Compact. Looking at all this data, is actually imperative for us to set targets, trying to improve health outcomes among people with diabetes. And the targets, we tend to be very ambitious. We want the Ministry of Health to really respond to the WHO. So instead of just proposing individual level metrics, there's a national level metrics, and we actually use the slogan of 80, 80, 80, 60. The white box represents the core metrics that each Ministry of Health or that particular country have to report and will need to meet this 80, 80, 80, 60, which means the proportion of population diabetes will be diagnosed should be at least 80%. And amongst those who have been diagnosed with diabetes, 80% of them should have achieved an A1C lower than 8%. Blood pressure lower than 140/90 millimeter mercury, also 80%. Then about the use of statin or lipid lowering among age 40 years and above should be 60%. And you may have a question saying, hey, why not just make it blanket 80% for all? But why is this 60%? Because we have done a systematic review and we realized that the statin coverage or the lipid lowering coverage is just about the median percentage from the global data, just 60%. And hence, remember, the national level metrics as proposed by the Global Diabetes Compact is 80, 80, 80, and 60. But is that just in terms of risk factor control or increased detection of those who are living with diabetes who have gone undetected previously? We're really looking into prevention. We have to think about strategies to halt the rise in diabetes and obesity. We'll talk more about that afterwards. Looking at the regional performance have been suboptimal. Again, you're looking at the 80, 80, 80, 60, just showing you a few countries in the Asian region. The highlighted in red boxes, meaning they actually achieve the target setting by the WHO Global Diabetes Compact. So at a glance, whether you're looking into high-income countries or region, for example, Hong Kong, Taiwan, they won't be able to meet all 4 national level metrics. At most, it's just 50%. Then what about low and middle income countries, whether it's Indonesia, Malaysia, Philippines, and Thailand? Most of us, we won't be able to meet the national level metrics as proposed by the WHO. So still, despite what we have done in the past few decades, we remain to deliver suboptimal quality of diabetes care. More strategies are needed, more attention will be needed in the untapped areas. So what are the untapped areas? Asians were actually facing a double whammy situation. I've shown you this progressive evolution of the phenotype of our Asian populations. We are well known to have lean phenotype, but because of the rapid urbanization, we have pollution, the world's most polluted cities are in Asia, we actually start to see a lot of the mixed phenotype transitioning from lean to those living with concomitant overweight or obesity. And not to mention the Southeast Asian region, we also have a high incidence of gestational diabetes and leading the intergenerational diabetes because of the increased risk of intrauterine fetal programming. We are hit by younger onset of diabetes due to younger onset of obesity, adolescent obesity in particular. Sharing with you will be what we have in the Malaysian data. This is purely observational. We examined about 1,500 patients with type 2 diabetes in 2008. And this another call is indirect comparisons that we collected in 2022 until 2023, about 5,000 of them. We realized the age of type 2 diabetes diagnosis in general has been younger than the Western population at 46 years old. But just about 20 years down the line, the age of type 2 diabetes diagnosis has been even younger at the age of 44. We also, the BMI has increased, the mean BMI from initial 27 up to 30 kilogram per meter square, which is about 16 years in interval. Waist circumference, Asian population actually using 90 and 80 centimeter for men and women respectively. And just looking at that, of course, this is a pool. There wasn't any segregation for men and women way back in 2008. It was about 94 centimeter. But here, men, 100 centimeter waist circumference, and female is actually 95 centimeter. We also have a strong family history of type 2 diabetes, 70% of them in 2008, but this has increased to about 3 out of 4 of our patients with diabetes who have reported at least one of their first degree relative would also having type 2 diabetes. So the obesity wave in ASEAN is real. If we were to look into the estimated prevalence just by next year, 2025 in Malaysia, 1 in 2 having either overweight or obesity. So if Brunei, almost similar. If we're looking at Indonesia, it's about 1 in 4. Thailand is about 40%. Singapore, pretty lean, it's just about 1 in 6. This would be one of the risk factors that we have not been properly being treated. If you still remember what I presented just now, the 5 risk factors, obesity and overweight wasn't part of the 5 key risk factors for the projections of the estimations for the cardiovascular event prevention. Tackling the overweight and obesity issue at each country would be a massive investment. What we are seeing here is just about 1/3 of the direct healthcare cost, but about 65% would be the unseen indirect cost, mainly because of productivity losses and also because of the premature death associated with the health conditions of obesity. And apart from cardiovascular and kidney disease, or we call it a CKM, cardiovascular kidney and metabolic condition associated with overweight and obesity, which have not been properly tackled. We also see an increasing burden of metabolic associated steatotic liver disease, or in short, it will be muscle D. This is not only in Asia Pacific region, it's about 1 in 3, also occur in North America, similar statistics, 1 in 3, and it's really increasing. And why is it important to really look into this emerging area? Because people with muscle D, they are at risk of progression into MASH, metabolic associated steatohepatitis. And again, they are at risk of developing liver cirrhosis and hepatocellular carcinoma with a higher chance of mortality. Is that just because of this? No, because the entire CKLM, cardiovascular, kidney, liver, and metabolic conditions, they are interlinked. This is the older term, NAFO and NASH. Now we're actually calling it as a muscle D and MASH. So looking at among the type 2 diabetes populations, 1/3 have the higher degree of steatohepatitis, MASH. More than half of them, they have concomitant muscle D. About those with obesity, 1/3 with MASH again, but 75%, 3 in 4, will have concomitant muscle D condition. Is that we also see a bidirectional relationship between all these conditions. Those who are living with steatotic liver disease, they're actually having 1.5 to about 2 times increased risk of either type 2 diabetes, major adverse cardiovascular event, or even chronic kidney disease. If we were to look into the Swedish population-based study, about 10,000 of them with biopsy-proven muscle D, they follow up from 1966 up until 2016. The median follow-up time is about 14 years, looking into the different degree of the muscle D versus the outcome will be the incidence of major adverse cardiovascular event, IHD, ischemic heart disease, stroke, congestive heart failure, or cardiovascular death. This reference group would be the population comparators. Those with simple steatosis itself, they are already at the higher risk of having MACE event. And what more, tend to progress from NASH without fibrosis, then the presence of fibrosis when there's a non-cirrhotic fibrosis, or those with the cirrhotic, the eventual stage of the liver progression, they would have the highest incidence of major adverse cardiovascular event. So are we really doing enough? There are also a lot of unmet needs while we're looking into our Malaysian diabetes cohort. There's about 5,000. I presented some data just now. We're looking into double warming situations, public hospitals, tertiary care settings. We involve 8 hospitals within Klang Valley. This is the urban area. The mean age is about 59 years old. Long disease duration, 15 years, pretty typical for hospital-based setting. 1/3 have cardiovascular disease. But looking at that, the mean A1C is still about 8%. And the BMI is pretty close to the Western populations, 30 kilogram per meter square. And again, these adults with a mean age of 60 years old, the waist circumference is actually 100 centimeter and 35. Actually, female having a higher degree of abdominal adiposity compared to men. As I mentioned, incongruent to what I presented, using the 1 million data among involving the Asian diabetes population compared to those non-diabetes at the initial slides, 60% of our Malaysian people with type 2 diabetes, they had concomitant albuminuria, and about 1/3 of them having an eGFR of lower than 60 mils per minute. Is it just purely Malaysia with an upper middle income country? It seems that it's not. If we're looking into the entire Asian database, this is from the Joint Asia Diabetes Evaluation Register, up until 2015, involving 11 countries and regions. If you just take looking into the attainment rate of A1C lower than 7%, actually most countries or region would not be able to meet that, just with Korea. The green bar represents men, and the orange bar represents women, and we realize actually women were less likely to attain the A1C of lower than 7%. We also see the similar observations if we were to look into abdominal adiposity again. If the waist circumference is lower than the sex-specific target, 90 centimeter and 80 centimeter for men and women respectively, again, most of the countries, they won't be able to achieve the waist circumference of lower than the sex-specific target. We also see the gender disparity in which that women were having a higher degree of abdominal obesity compared to men. What will be the economic impact of obesity in ASEAN? This is the estimation way back in 2018, just highlighting a few countries with a high degree of obesity like Indonesia, Malaysia, Philippines, and Thailand. The estimated direct cost of healthcare expenditure is actually about 2%, but look at the estimated indirect cost. It's actually way higher than expected, can be range from 3% to 10%. So in conclusion, shown you that Asians with type 2 diabetes compared to those without type 2 diabetes, we still have 2 times increased risk of cardiovascular events and death. And we also saw a higher degree and a worsening severity among young people and women. Despite optimum risk factor control, there's residual cardiovascular kidney risk. I've shown you local Malaysian data looking into the all-cause death rates for diabetes have not decreased over time, despite what we have done in the past 3 decades. And even though pathophysiologically, we understand that Asian with type 2 diabetes is characterized primarily by beta cell dysfunction with less adiposity, but we're actually facing a double whammy situations where the obesity wave in Asia is real. And we have more unmet needs looking into the cardiovascular kidney, but now also liver prevention. So it's really time for Asians and even Malaysians clinicians to reframe the conversation, not only to our patients, to the community, and also to the relevant stakeholders and policymakers. In the past, we are aiming that we are looking into people with diabetes. We want to prevent them from developing microvascular and macrovascular complications. We want to prevent them from dying prematurely. But with the advent of newer generation guideline-directed medical therapy, we are looking into prevention. We don't want them to develop even the first event. We're also looking into diabetes remission. But really now, based on all this data and the unmet needs that I presented to you, within at least in the Asian region, we have to look into the primordial prevention. How are we really to tackle the overweight and obesity issue to prevent the worsening of the double whammy situation in Malaysia and in Asia? So thank you. And sharing one of the ongoing effort by our Ministry of Health, Zulkifli is actually our Minister of Health, due to the increasing burden of diabetes and obesity in Malaysia. In May, we actually declared war on diabetes and trying to really strengthen the sugar-sweetened beverages tax that has been implemented since 2018. And we may actually look into more policy relevant in terms of for the obesity and diabetes prevention. Thank you. And we open for discussion. Over to you, Hui.
Yeah, it's an excellent presentation. Thank you so much, Dr. Lim. So I think now we're in the Q&A section. So if there's any questions, yeah, I see Mo's hand is raised. So Mo, go ahead.
Hi, so Lee-Ling, this was terrific. I was curious, you mentioned that the vast majority of diabetes in Asians and maybe more so in Malaysia tends to be related to beta cell decline. I wonder if you've, the work from Emma Alquist and colleagues in Sweden, whether you've replicated those same phenotypes in your population with some of the data you have. And if so, what is the distribution of the more obesity-driven phenotypes, if you will? And then my second question relates to sort of whether those phenotypes are responsive to GLP-1s, at least in your clinical practice.
Okay, good questions, Mo. Thank you. So first question is whether we have done any of the clustering of our diabetes phenotype. The work is actually ongoing, because we actually require additional data collections. If we were to look into our diabetes population, especially those with young onset diabetes, the C-peptide measurement together with insulin antibody may not be available for all patients because it's actually out of pocket. The insulin antibody may cost about $300 per patient. Therefore, we are actually doing a cost study trying to looking into young onset diabetes. We really want to know whether we're actually seeing the similar type of clustering as what the Swedish population has done. Dr. Mohan, I think the Indian group they have data, and they even published before, and they found that they actually have two new clusters compared to the Swedish work. So second question is phenotype, the diabetes plus obesity phenotype, whether we're actually seeing a similar response towards the GLP-1. Our patients actually respond pretty similar to what we've observed from clinical trials. However, so let's put into two different perspectives. If it's just diabetes population, their response to GLP-1 has always been about 20 to 30% less response to GLP-1 in terms of weight loss efficacy compared to those obesity alone. So we're also seeing this the similar reduction in efficacy compared to the trial data. Second thing would be, what if we're actually looking into obesity using a GLP-1 in Asian, obesity using GLP-1 in Western, and again, Asian, we don't perform that well. We also have about 20% reduction in the efficacy with the use of GLP-1. And hence, I'm just trying to think, saying that perhaps to tackle the overweight and obesity issue in the Asians or Malaysians, our treatment algorithm would differ slightly to the Western population. Perhaps a combination approach that would be able to provide a greater degree of weight loss. What do you think?
Yeah, great. I mean, thank you. It's a sort of an ongoing conversation, right? Because in addition to what you said about the GLP-1s, so far anyway, the few prevention trials that tried lifestyle in people with IFG who don't have IGT don't seem to work as well. And so, if lifestyle isn't really as strong, or the DPP type lifestyle that we've tried, which is sort of calorie restriction, fat restriction, and 150 minutes of physical activity, if those aren't really as effective, then we've really got to scratch our heads and think about, what will be effective.
Yes. Even the diabetes prevention trial, the Asian population reported about 30% reduction in efficacy.
Yeah. So, I mean, so all of this, I think, points to a physiology that we really need to understand better before we figure out the treatments per se. But we also can't sort of sit around and wait with our hands on our laps saying, hey, we can't treat you because we don't know what to do. It's a tough one.
Definitely. Yeah. Perhaps you can think about something. We need to brainstorm.
I think this is a very interesting conversation. So I have another question, Lim. So you presented this kind of a low performance of goal achievement in terms of A1C, blood pressure, those kind of things in the Asian population. I'm wondering if there are studies talking about the undiagnosed diabetes and the first A1C A1C measure upon diagnosis. So, because as I understand that there's a much higher undiagnosed diabetes rate in Asia, and also the first A1C measure should be much higher in the Asian population because of this delay in diagnosis. So, are there any documentation in that?
Thank you, Hui. Very practical. So, I mean, first thing to address your questions would be the undiagnosed proportion. Yes, it's actually higher in Asia. Just sharing the Malaysian data, a population-based survey is done every 4 years. So this year was in May, during the launch of the War on Diabetes. That was the revision of the 2023 National Health and Mobility Survey. So prior to that, the proportion of undiagnosed diabetes was 60%.
Oh, wow.
Yes, 60%. And hence, in the past 4 years, the ministry has actually tried to ramp up these screening activities. So that there are actually at least 2 initiatives that actually gather support from the entire public healthcare system, as well as the public-private partnership network. So we managed to reduce the prevalence of undiagnosed diabetes to about 45%. But then the subsequent question that we tend to be asked, or we ask the Ministry of Health officials, it will be, we have detected them, some of them, and some of them, they actually still drop out from the healthcare system. Okay, yep. So this is one gap that we haven't really addressed. So back to our second question, is about the comparison of the regional performance. Then all this actually we extract from the country specific registry reports. So I can't be 100% sure saying that is the adverse diagnosis, but based on just using the Malaysian diabetes report in general, is the primary care, the median diabetes duration for them would be 4 years. So judging from that, it won't be just adverse diagnosis for A1C, and hence it won't be an overestimation of the proportion being reported.
I see. So we had a study with the CDC a couple of years ago. So basically, we were comparing if there is only one public health intervention going to be deployed. Should we focus on A1C control? Should we prioritize on BMI control? Should we focus on blood pressure control? And should we focus on LDL if there's only one choice to be deployed? And our results indicate that there are actually two options. Both works. So we could either focus on A1C or we could either focus on the BMI. And so as when comparing these four options, and another interesting story is that for the A1C, some control is good enough. So basically, the idea is that we found getting those with the highest quartile, those with completely uncontrolled diabetes, into some control is already good enough to produce a lot of health outcomes. But the further reduction does not really mean that much. But for the BMI, the more you reduce in a healthy way, the better. So it's kind of like what we give the CDC about, like the public health recommendations. I feel it's even more so in the Asian population.
Do you see a U shape, or is actually a linear curve?
For
sort of like a J shape?
For A1C, it's kind of a U shape or a J shape. So it always the most of the benefit come from some control, but not a lot of benefit come from further control. So from a population perspective.
If it's a BMI, you're also seeing a same trend. Is a
BMI? No, where we actually see additive trend, a monotonous trend. Yeah.
All
right.
It'd be interesting to know how you actually do the estimation.
Yeah, I can share you the paper. So actually,
thanks.
The model I mentioned to you, the simulation model, so is ready for deployment and for the country-specific calibration. So if you are interested, I'm happy to work with you to get a Malaysia version. So currently we're working with Ed's team to do a Europe calibration, and I'm also working with Dr. Mohan for Indian calibration, and one from Fudan University for Chinese version. So our goal is to provide this kind of a network support with countries that's interested to use our model to this country level policy prescription. So if you're interested, that could be, well, I think we had this conversation last time we met.
Correct.
Meeting. So if you are interested, I'm happy to further this conversation with you.
Okay, definitely.
Yeah. So I see Pepel's hand is raised. So Pepel.
Can you hear me?
Yes.
Okay, thank you for the nice presentation. I do have a question. We know that social determinants of health plays a very important role in the management and the treatment of diabetes. I'm just wondering, in Malaysia, is there any kind of strategy or initiatives that integrated the social determinants of health into the routine clinical practice?
Okay, good question. So first, in order for us to include in routine practice, we need to have data to support. We don't have as comprehensive data on SDH, social determinants of health, compared to the Western populations. Just a handful of literature has been done. And of course, we also see a high burden, not only in terms of mental health, also socioeconomic status. I'm not sure whether all of you are aware about it. Using our population-based survey, the health literacy level among the Malaysian population is actually suboptimal. So about 30% of them actually having poor health literacy. And this is also one of the things that you may not see a very high efficacy when we actually try to roll out a lot of community awareness programs. But yes, we are really trying to generate more data in terms of SDH and help us to prioritize what would be the specific type, because we can't roll out everything. We need to prioritize our intervention strategies because our resources are actually pretty limited.
Thank you.
All right, so we have time for one more question. All right, so I have one, so maybe I can take the opportunity. It's very interesting to learn that both the GLP-1 and the DPP performed less well in the Asian population. So what could be the hypothesis here? Is because the Asian have a different type of obesity, or our baseline obesity is not as high as what most of the people included in the trials. So what would be like the hypothesis here?
Yeah, I mean, good question. I mean, initially when I saw the data, the first thing that I'm thinking is we always say that Asians tend to have poorer incretin effect. Our incretin defect tends to be worse compared to the Western population. And hence, we're actually using all this incretin therapy, for example, GLP-1 receptor agonists. We should expect a better response because they're really tackling the pathophysiological defect in the Asians with diabetes. But ironically, we're actually seeing the opposite direction. And hence, if you were to compare the clinical trials, which run in purely Asians, for example, Surmount China, using tirzepatide is a dual GLP-1 and GIP. Even if you look into the 2.4 milligram weekly of the subcutaneous semaglutide in the STEP trials versus the equivalent among the Western populations, again, 20 to 30% reduction efficacy. Looking at the data, could it be because, as what you have said, our BMI of that Asian-specific clinical trials are actually lower, and hence they may not lose that much? Or is it because perhaps there's having differences in terms of proportions of men and female, and therefore their response would be different, biological mechanistic differences? It can also be related to the different proportion of pre-diabetes population or intermediate hyperglycemia populations, because the dysglycemia group versus the purely just obesity alone group, the mechanisms would differ, and hence this will actually perhaps contribute to the differences into the efficacy that we see with the use of GLP-1 or dual GLP-1 in Asian populations versus the Western. We do not have the real answer because we do not have any head-to-head comparison trial as of now.